So thank you again for being willing to be interviewed by me. I'm really excited because I've kind of like known a little bit about your work for some time now because you've had such a major role, but I'm like just curious to learn more because you've had, I think I checked, you've had over like 40 years at UNM, over 25 years as the Dean of the School of Medicine, and over 15 years as the Health Science Chancellor. Is that correct?
That's right.
Yeah, so that's a lot.
It's a long time.
Yeah, so, well, just to start it off, I mean, for me, because it's like my first year, I think a lot of times we get asked, like, kind of what we got through was, why medicine and why New Mexico? So I kind of just wanted to start off by asking you that.
Oh. Well, I first wanted to go into medicine when I was very young, actually. Mostly because I liked the idea of trying to help other people. And no one else in my family were physicians. In fact, no one else in my family ever even went to college. And the only role model I had for a physician was the doctor that would give me my shots when I was a little kid, which I was not enthralled about. But nevertheless, it was just the idea of being in that kind of a position to significantly make somebody's life better.
Mm-hmm.
So that had always been in my mind. My father was in advertising, and he had in his mind that I would go into business with him. And in fact, as I finally got accepted into just regular undergraduate college, he asked me one day, and I remember this day very, very significantly. Our family would often go on family trips in a car. We would take car trips. And this one year, just before I was about to get into college, my father, it was me and my two sisters in the back seat, and my mom and dad in the front seat. And we were driving, he was driving along, and he said, "Oh, well, so what kind of business classes are you going to be taking in your first year of college?" And I said, I decided to go into biology, Dad. And there was just complete silence in the car. And it was the rest of the trip, nobody said anything. So my father even printed up a sign that said Roth and Son, because it was everyone's understanding that I would go into business with him. So it was very dramatic at that moment, where I divulged that I wasn't going to go into business and get a business degree and work with my dad. But everybody got over it, and it was fine, and I was happy that I made that decision.
Well, I mean, you ended up being kind of like in a role where you're also like a leadership position. That's, I think, very similar to perhaps an entrepreneurial mindset. So maybe learning from your dad or whatever you did ended up helping too.
Yeah, I think it did. And I think you're right. There were many things that I thought about doing, having had those ideas generated from an entrepreneurial perspective. So when I was a resident, I started my own company.
Oh.
And in fact, two companies. I created the very first urgent care center in the Southwest. And it's still an urgent care center in the Northeast Heights. Eventually, Presbyterian bought me out. But that was kind of exciting and fun to do. And I had to find investors to come up with money, because I was only a resident at the time and I didn't have any money. And then there was another company that I created with a friend that hired physicians and sometimes other residents to moonlight. So it was called EMS Incorporated. And for several years, I was able to set up schedules and arrange for coverage for other hospitals, ERs, so that I was able to generate enough money to start paying back my student loans at the time. So it was, that all generated from a spirit of entrepreneurial perspective. So you're right about that.
Yeah, that sounds very interesting. And so these were kind of like the first, because you ended up creating a lot of programs throughout your career. Were these kind of the first ones that you started out with?
Yeah, those were the first real bold approach to creating a new kind of enterprise. And then after a while, when I was done with my residency program in family medicine, I joined the faculty.
Mm-hmm.
And then just tried to think about better ways of creating programs here at UNM.
So that kind of experience helped you in being able to do that even now.
Yeah, having some business background, understanding finance and budgets, how to create contracts and developing business relationships with others, all was good experience in becoming a faculty member here at UNM. And very few other people actually had that kind of background. Most people, just like all of you, went to high school, maybe had a gap year or two, and then went to college, and very few really had the opportunity to be in other fields. Although there are some. We have as you may know, we have a very non-traditional student body.
Right.
There are several medical students who actually had other careers before they started medicine.
Yeah, it definitely makes it exciting as a first year student to come in and just have people who know so many different things about other stuff and be able to contribute in that sense. So you kind of talked about like what I was going to ask you a bit more about like discussing some of the initiatives that you were able to start at UNM, and like which ones that you kind of felt like you found very important and kind of challenges or breakthroughs that you had to go through to start those.
Well, the first one obviously is the BAMD program.
Yeah.
And
thank you.
and I think it still is an extraordinarily important program for the state of New Mexico. After I became dean in 1994, a couple of years afterwards, I started looking at data, trying to get a sense of where our graduates went. And the trends at that time, and which were stable for many, many years, was that about 25% of our graduates would go on to residency and then come back to the state of New Mexico.
Mm-hmm.
And I felt that was too low. It seemed like if we were taking in a lot of students from New Mexico, which we were, there would be some incentive or some greater interest in returning home and helping our state deal with the physician shortage. So at that time, there was a part of OMSA, the Office of Medical Student, the Medical Student Office for undergraduate medicine, kept data, and it showed that students who had roots in a community would often return to those communities. and that students who were underrepresented would often come back to serve the community that they came from as well. So I thought what we should do is to reach out to the whole state and offer a program for students from around the state who would come into the University of New Mexico, do 4 years, and then be automatically admitted to medical school. And there really hadn't been any kinds of programs like that before. So I met with the dean of the College of Arts and Sciences, and I laid this program out to that dean. And he was very enthusiastic about it. He thought that was great. So we both pulled our respective faculties together, and there were leaders who really embraced the idea in the medical school, and there were several on the main campus in the College of Arts and Sciences. And so for about 2 years, they met and helped forge a curriculum for the undergraduate portion. And we had to work with our accrediting agency and with other outside groups to make sure that when students went through this program, that it was legitimate and that the state liaison committee for medical education would recognize this program as being legitimate. So the first few years, it was challenging. We did admit lots of students, but as you're all aware, very often some of the smaller high schools in New Mexico, public education isn't the best in the world. And so very often students who were in the top of their class in like JAL, New Mexico, just found that they weren't able to compete in college. So there were problems with math in particular and science, where they just didn't have adequate preparation. So several of the students in the first few years had to leave the program because they weren't able to continue and pass all their courses in the undergraduate portion. So the other challenge was we didn't want to have students have a large student debt. Mm-hmm. And we did have information and data that would show that students who had a high student debt would often not practice in a rural area, and would often, it would be more difficult to choose a primary care specialty because that's pediatrics, general internal medicine, family medicine are one of the lower paid physicians. And so there was this incentive for students with high debt to choose something like surgery or some specialty that would offer a much higher income. And so I had to go to the state legislature to request funds to hire a few more faculty and to offer scholarships. And when I laid this program out to the legislature, they loved the idea because they were trying to figure out how do we get more doctors to come and practice in New Mexico. Mm-hmm. And I offered them this opportunity. The logistics, however, were such that the legislature can only fund the next fiscal year. So they couldn't say, yes, we'll give you enough scholarships for more than just the first year of the BAMD program. So I had to go back to the legislature for 4 years in a row, asking for the next year's funding for the program. And every year, even a year where the state was facing some deficits, this was one of the few programs in the whole state that actually got more money
Oh, wow.
because it was so well received by both senators on the Senate side and the House of Representatives, that there really wasn't even a question about it. So it was a challenge, but it was something that was obviously such a great idea that everyone we spoke to embraced it and wanted to support it.
Wow. I didn't actually know that much about like
It was the politics of New Mexico. Thank you for the border.
Yeah, I think, and it's a lot to be able to go and propose something to the legislation and also have them be totally on board with it, which is
And funded, yeah.
yeah.
Are you interested in health policy and that kind of thing, leadership, administration?
Yeah, absolutely. And that's definitely I think part of the reason why I wanted to talk to you, because I'm curious to hear how you were able to kind of get involved and push those things, because I think it requires a lot of different type of skills to be able to come up with those ideas and articulate them well enough to get things passed.
And I had a lot of help too.
Because so many faculty really loved the idea. Several of them came forward and wanted to be leadership, like Dr. Romero Leggett had been involved with the program from the very beginning, and Dr. Sapien. There on main campus, there were several other directors of the program on main campus, but they all helped craft a message. And I was the one who had to actually sit in front of the committees and answer questions and present the ideas, but it was with a lot of people's help, who would also be able to talk to senators and representatives offline. So it wouldn't necessarily have to be just during a committee meeting. But if many of them knew those legislators and were able to answer questions, not necessarily just during the time when there was a committee meeting.
Yeah, and I thought it was also interesting that you brought up, so statistically, people with greater debt do choose fields that are will pay them more and helps them. So is that kind of also as well why because I know you kind of started the idea of having a free medical school if you commit to New Mexico, is that correct?
Yes.
Okay, so was that kind of the similar logic?
I felt that choosing a career
And making the commitment to be a physician was such a powerful passion and such an important gift for society that society should not create barriers, and particularly not financial barriers. And so if there was a way that we could create a setting where if you qualify and are admitted to medical school and are willing to commit to practice, come back after training and practice in the state of New Mexico, the state should come up with the funds to support those students. So leading up to that, I was able to reduce tuition every year.
Okay.
And we were the only medical school in the country that actually started going down on our tuition rather than going up in tuition. And then about a year or two before I retired, I just felt like we needed to take the next step and have the state come up with enough money to pay for tuition and fees for everyone accepted to medical school. That was a tough year. The state was facing a deficit. We were only able to get a few $100,000 to support, I think, 3 or 4 medical students for free tuition for the 4 years, with the idea that we would eventually continue to go back to the state and ask for the rest of the money. That was around 2019, and then 2020 we had the pandemic.
Okay.
And so there was a lot of changes going on. A lot of people had to switch priorities. Everyone was rightfully concerned about whether we had enough resources to take care of people during this pandemic. And so whatever extra funds were available, many of it, rightfully so, went to areas like public health. I don't know if you remember, but the state, although they received a lot of federal funds, also had to pay for more workers, more healthcare workers, the vaccinations and immunizations. So it was a very rough time, and then I retired.
Right.
And there were new priorities for the medical school.
Okay, that's fair. So kind of like when you were dean and you kind of coming on, what did you kind of hope to change? And now that you're no longer in that position, where do you kind of see that the med school is still going? Because it sounds like a lot of changes had happened.
Yeah, we did, looking back on it, I think we did a lot.
Yeah.
Even the way the faculty are compensated. So in an academic institution, in a university, faculty sign contracts, and the contract says, here's what you're going to get for the year. Or on main campus, it's 10 months. And there are no measurements of quality that are tied to compensation, like there is in business. So we completely changed the compensation plan for all of our faculty in the medical school. And it was eventually adopted into with nursing and pharmacy as well. But we said a certain part of your compensation, your salary, should be simply like it is on main campus. If you're an assistant professor, you should get a certain amount of money as a faculty member. And that would be your base salary. But then we said if you want to have more funds, more compensation, it would have to be based on performance.
Mm.
And so if that would be called the supplement to your contract salary. Your contract salary with both the base and the supplement together would constitute a little bit less than the average salary across the country for whatever discipline you were in or whatever status as assistant professor or professor. And but that supplement, the chair of the department would have to work with each faculty member and say, okay, well, this year, looking forward, we expect you to teach a certain number of hours. We expect you to get some grants. We expect you to see this number of patients. And if you didn't, then the next year, your supplement would go down.
Mm.
And then on top of your contract salary was an incentive component. So if you exceeded those targets that your supplement was based on, you would be eligible for even like bonus money. So this concept was unheard of in a university before.
Yeah.
But what it allowed us to do, because we felt we needed to increase our research mission, and we had to go about performing patient care at a higher quality, and we wanted some incentivization for the faculty to teach. It resulted in dramatic increases in our research programs, more faculty interested in teaching, and a lot of work done in reviewing the manner in which we were delivering patient care and improved our quality of care. So that compensation plan, we were one of, I think, 3 medical schools in the country that developed that kind of a compensation plan. And we were asked to go to national meetings to explain how we did all of that. Actually, it required the faculty to vote to change their own compensation plan like that and put themselves at risk for performance.
Oh, wow.
So, and they all adopted it. And today, it's rare to find a medical school where that's not the compensation plan. So it's really was a trendsetter for the whole country. And I think everyone found that it was to the benefit of the individual, because if you work hard and if you do a good job, you should make more money.
Right.
And there should be incentives for you to do that, as opposed to making whatever money you were contracted for, and not really have any kind of metrics for performance at all. So particularly the younger faculty really loved the idea, and felt that the older model was not conducive to modern ways of thinking. So that was another program. And in academics, in an academic medical center or health sciences center, there are 3 main components that make up the clinical enterprise. There are the faculty who become the medical staff of a hospital. There's the hospital, and then there's something called a practice plan. And the faculty practice plan is an organization that contracts with third-party payers like Blue Cross Blue Shield or Medicare or any third-party payer, and on behalf of the faculty who work as clinicians. And so about 1/3 of all of medical schools in the country owned all 3 of those. They had their own faculty, they owned the hospital, and they owned this practice plan. And so we were one of those. And the practice plan would actually be the entity to which reimbursement would flow. So if I was in the emergency room and I saw a patient, there would be a bill generated. That bill would go to whatever the carrier was that insured the patient. The monies would flow to the practice plan. And then there would be a formula that would send those dollars from the practice plan back to the School of Medicine to fund the salary of the faculty.
Okay.
So that's sort of how that whole thing worked. And at the time that I was dean, shortly actually before I became dean, and when I was the associate dean for clinical affairs, we re-looked at that formula that we had at that time. And at the time, there were funds that would flow to the practice plan, and there wasn't a lot of money that was being collected at that time. They would have the funds. Some of it might go back to the faculty, some of it would go to maybe funding research, doing some other things. But I, along with others, felt that if you were the one working, generating those dollars, the bulk of those dollars should come back to you.
Mm-hmm.
And so we completely redid the faculty formula and which is still in existence today. So the people who generated the funds would actually gain the majority of the reimbursement for delivering services, whatever they were doing. And I guess the other program that I think you kind of alluded to when I was talking to you earlier was in disaster medicine.
Right, yeah.
And creating the Center for Disaster Medicine was something that was very much, I felt, a part of emergency medicine. And so that was another initiative that I was very proud of being able to help create and develop.
Yeah, so for that, so my understanding is you started the Center for Disaster Medicine here, and then also the first civilian disaster center in the nation here. And then you also headed the 9/11 team to address that, and then that same team went to Haiti for the 2010 earthquake. Yeah, can you tell me more about that and like what challenges or things that you faced there as well? I mean, that's like a very huge endeavor.
Yeah, that was an interesting time.
Actually, the whole thing started early on in President Reagan's term. And there had been an earthquake in Alaska, which was a huge earthquake. And fortunately, though, for Alaska, it's very rural and there was very little damage. But Reagan, having just been the governor of California, had thought, what if that same magnitude earthquake would happen in California or in the main 48 states in the continental US? And he helped modify the National Emergency Response Plan into something called the Federal Response Plan. And it was an adaptation of what had been in place in World War II, where there was a consortium of private hospitals or non-military hospitals in the United States that agreed to take the victims of war or soldiers who might have been wounded, and if it would overpower the regular military hospitals and the VA hospitals, that non-military hospitals would be willing to accept those patients. And that worked very good in World War II, and in Korea, fortunately, there weren't as many casualties in Korea that required them to trigger that response. But the format that had been developed in preparation for that, where there would be mass casualties all of a sudden, seemed to be a good beginning for some kind of a civilian response, a domestic response in the event of a disaster in the United States, like a mega earthquake in California or elsewhere in the United States, where you would have tens of thousands or even more casualties suddenly overnight because of a particular thing. And so Reagan created, his staff and others at his request created the Federal Response Plan. And within the Federal Response Plan, so they would have things focusing on transportation, communications, all the different pieces of infrastructure that you would need to mobilize nationally to help provide support for whatever area the United States had suffered this disaster. A part of that, one of the elements of the Federal Response Plan was the National Disaster Medical System, NDMS. And it was NDMS, the structure of it, what they had envisioned was that the basic components of the National Disaster Medical System would be these Disaster Medical Assistant Teams, or DMATs. And that it would not be formed from the government, but would come from the private sector. The fear at that time was if there was a major disaster in the United States, that and if it was the military or the government that would have to respond, the enemies of the United States would take advantage of that and do something else against the United States elsewhere around the world. So it was important to the federal government that the private sector, the civilian sector, would step up, and there would be a structure that would exist to respond to these kinds of events if they happen. So the first part of creating NDMS was the newly identified director of that program traveled to the 50 largest cities of the United States. And Albuquerque was one of those cities. And when he came, he invited all of the hospitals, the medical community, local government, the VA, and other major leaders. And I was invited because at that time, I was the division chief for emergency medicine. And there were other people from UNM Hospital that came too. I think I was the only doctor from UNM. And so the director, there must have been a couple of hundred people, and it was all in the basement of City Hall, and they had this large meeting. And the director laid out what the idea was of this new program. And he said, he then ended this program and said, who would like to take the lead for this program here in New Mexico? And there was complete silence. Nobody wanted to volunteer. But I was thinking, disaster medicine, we could make a specialty out of that. And it seemed to be consistent with what you would want to be able to do as an ER doc, immediate, you treat somebody with acute injuries, life-threatening injuries. And so I raised my hand and said, I'll do it. And so that's when it got kicked off. They went around to all these states. There were very few people that showed any interest in it nationally. And so we were able to, I was able to partner with UNM Hospital, and the hospital agreed to participate as a backup in the event of mass casualties. If something happened in California, they would transport if California couldn't handle it, they would transport them here to Albuquerque, to UNM. And so we began promoting it around the state. And one thing that's really marvelous about New Mexico is the sense of volunteering. And it's probably because so many communities in New Mexico started off in pioneer fashion, where neighbors really had to help neighbors. Mm-hmm. And it's not unusual to find in small towns in New Mexico that the chief of police might be a volunteer firefighter, right, or the mayor might be somebody who would volunteer to do other things, and the whole community would be together helping one another. And so we were able to have about 250, 260 volunteers from around the whole state that were enthusiastic about being part of this team. So we created the New Mexico Disaster Medical Assistance Team, and we had nurses, pharmacists, doctors, but we also had to the team had to be structured in such a way that if we were sent someplace in response to a disaster, that we would have to be self-sufficient for at least 3 days before we would get any kind of resupply or help in any fashion. They would transport us to someplace, park us somewhere, and then we were on our own. So we had to have logistics, food, shelter. We had to think of every possible thing that we would need to be completely self-sufficient for a whole 3 days. And so we had a lot of those people that would be part of the team. And you know, in New Mexico, there's a lot of outdoors people.
Right.
And this was just something that they were enthusiastic about too. And so we trained year after year, maybe a couple of years. And then there was a hurricane in the Caribbean.
Mm.
And the St. Croix, one of the U.S. Virgin Islands, was completely wiped out. And we were called up. It was the very first time any civilian team were deployed to a disaster. And so we got there, had our whole team there, and this was in August, I think. It was still very, very hot and very, very humid. And we were told, bring everything you can, but don't worry, we're going to have supplies there for you. You'll have food, and we'll give you a tent, and we'll give you sleeping bags and boots. So we arrived. First of all, we didn't quite want to trust the government in having everything we needed. So we brought our own supplies with us. But the tent that they had was an old World War II tent. It was just canvas. And nobody kind of remembered or knew how to set it up. And there wasn't anyone there to help us do it. So we kind of figured that out and got the thing set up. The boots they gave us were Arctic boots. And they were all size 7.
Okay.
Which didn't quite fit most of the members of the team. And the only food that we found were sardines that they had shipped in from someplace. So the logistics guys that we had, fortunately we had a lot of our own food. MREs, these were like dehydrated food, but it was still something that we were able to secure. And what little foraging we could do on the island to get not just food, but in St. Croix, they don't have fresh water.
No.
They actually had to have a desalinization plant that would take seawater and make it into potable water, drinking water. But that was destroyed. So we had at least some access to fresh water for the first few days. By that point, the U.S. Navy they have ships that are desalinization ships.
Oh.
And they finally docked at one of the ports in St. Croix, and we were able to get fresh water, finally, to help support the team. The hospital that was there was completely destroyed. The few physicians that were on the island, full time, had actually left because they didn't want to be there during the hurricane. And so we wound up doing everything. We delivered babies. We provided medication for patients with high blood pressure, diabetes. We kind of anticipated most of the things that we needed. Some patients were really ill or injured, and we had to fly them out to Puerto Rico, to the hospital out in Puerto Rico. But we were there for a few weeks, and finally they were able to bring in something like a MASH unit. This is, it's a military hospital that
Okay.
came from Georgia, I think. And they didn't have any staff for it. But
Is this
they
like
did,
another ship, basically?
well, they flew it out, actually. And they had staff that was there to help build it. And it was very quick. They got it up in only like a day and a half. It took them to do this because it's designed to be used in warfare and to quickly create a hospital setting in the field to deal with casualties in a battlefield. So they were able to get that up, and then we staffed it. We took our team, and then we were the ones who worked within it. And so we had to improvise. It was a very austere environment. But, you know, we all felt at the end of the day that it was just so rewarding to be in a position of not just being the very first team that ever did anything like that, but to be there helping people when they were in their most dire circumstances. And if it wasn't, and we knew if we weren't there, there'd be a lot of people that would have passed away, would have died. So it was very, very rewarding. In fact, we had, when we were finished with our tour, we were then replaced by another team that they sort of took people from multiple states because there wasn't any single team that had it together like we had. So we were finally relieved with this other team that came in. And at that time, President Reagan's vice president was Dan Quayle. He was the vice president. And his wife actually flew down and flew back with us back to Washington, D.C. And congratulated us for being able to respond so quickly to this disaster. So
Wow.
It was really quite an adventure in that sense as well.
Wow.
So that was, and the team still exists today. We responded to hurricanes and earthquakes. We went out to Hawaii. We were at Northridge earthquake in California. Andrew, Hurricane Andrew in Florida. And then I had made the transition mostly into administration, moved out of emergency medicine, and then in the 9/11 happened.
Mm-hmm.
And I said, I just have to go to that. That was, even though I was the dean at the time and I was, had so many other responsibilities, I felt it was my duty to respond to that terrible event. And so I led our team to New York, to the Twin Towers, and we had the night shift, and there were other teams by that point that had already developed around the country, and they took the day shift, evening shift, and then we were the night shift, 11 to 7, from 11 at night until 7 in the morning. And which was very surreal because there were these giant floodlights on at the scene. And so you didn't really see much beyond what the floodlights showed on the ground. And the smell was just terrible. And unfortunately, we were there hoping that we would be treating injuries, but there were no survivors. So we were mostly treating the rescuers, who would just 24/7, they would constantly be going through the rubble trying to find people. and they only found pieces of people. And so it was very depressing, because that, what motivated all of us was helping other people. And it was just futile. There were no survivors. So we did wind up, an interesting little side note was there were several teams, search and rescue teams, that used dogs to try to find victims that might have been buried. And the dogs couldn't find any survivors. And apparently the dogs themselves started getting very depressed, and the handlers realized that they just couldn't keep on going. And but we did wind up treating the dogs because after the buildings collapsed, it generated so much heat, and the dogs would go into the rubble and they would have burns on their paws.
Oh, wow.
So we would be treating the dogs. Sometimes they'd get lacerations, and we'd have to suture them up. Eventually, the handlers actually got little pads for their paws, so they would protect their paws when they were in the rubble there. But that was my last deployment, and but the team still is around today, and they've responded to Haiti, as you had mentioned, and floods in the Midwest, the hurricanes down in Louisiana over the years. So still very, very active.
Are they all composed of like physicians as well, or is it?
Yeah, physicians, all members of the healthcare team, plus people who would just be focused on logistics. So we'd have cooks, and we'd have people who would know how to set up a camp. And we had the head of the Boy Scouts camp from northern New Mexico that who did join our team and help us create the whole campsite for us.
Wow.
So we were,
A lot of planning and logistics and
yes,
getting people
all of that
together.
stuff that you wouldn't think about,
Right.
but we were fortunate in having all of that talent.
Yeah. Is this kind of, because I know you also worked in the Department of Homeland in the public health group, or like the security boards as well. Is it,
Yeah, I was asked to work in a committee, a federal committee that I can't remember what it was called. It was Open Borders, Open and Secure Borders, something like that. But it was part of the purpose of it, and it was a joint committee of the Homeland Security and the Department of Health and Human Services. And it was immediately after there were, I don't know if you remember, but there were a series of envelopes that had anthrax in them that was sent to public figures across the country. And so the feds thought, what would happen if we were to be attacked with bioweapons? So the purpose of this group was to think about how would the country respond to a bioterrorist attack. So, we looked at anthrax, and we looked at smallpox, and had a lot of very, very smart people working with us, and it was an interesting exercise. That was the time when, and recently with the pandemic it's when they were able to create these very rapid techniques to create new vaccines using RNA. At that time, though, before this new technique, it would take at least 6 months to create a vaccine against anything. And so the whole country would be vulnerable for those 6 months. And that's where the strategy of lockdown, masks, people having to be separated, quarantine and isolation approaches, which were the mainstay of a public health response to an epidemic or a pandemic, which we had to draw on because some of the agents that had been developed by Russia and that were even aware of through the CDC in the United States were so lethal that if exposed, you had 24 hours and you would die. We were looking at things like Ebola, other really terrible diseases, and some of these agents were developed some of them were developed to actually create mortality, but some agents were developed to increase morbidity. The difference being you had certain microorganisms that were tended to kill other people and spread very rapidly, and other agents that were created to just make a lot of people very, very sick. So it would tie up hospitals just like the pandemic did. Huge resources would have to be called upon to treat all of the patients who were very, very ill, allowing whoever did this to mount some other kind of an attack against the United States.
Mm-hmm.
So it was felt that it was important for us to begin thinking in those terms and to have a lot of experts and leaders around the country to come together and try to develop a response in the event of something like that.
Wow. Wow, it sounds like you've done a lot of different things. I was going to ask too, so it sounds like, a lot of the work that you've done has been focusing administratively a lot on looking at financial things to make sure that, people can serve the underserved communities, and then also focused on helping people and getting out there and being at sites. So kind of what are the values that drive a lot of your decisions? Because as a leader as well, you're doing a lot of those. So.
Well, I think that you touched on it. I think we always would focus on ways to provide excellent care for everyone. And so underlying that premise was dealing with health equity issues in New Mexico, thinking about vulnerable populations, either vulnerable because of their income or their rural nature, that they were far away from healthcare facilities. Knowing that we would have to be the last resort here at UNM for a lot of the citizens of the state of New Mexico if they were in severe crisis medically. And so building our enterprise to be adequate to meet those needs, as well as working with all of the rest of our partners in the healthcare industry in New Mexico. And that's how we helped create the trauma system for the state. We had that kind of a cooperation in even responding effectively to the pandemic. Presbyterian and UNM and Lovelace and the VA and other major healthcare facilities already had worked together in so many other ways. It was easy for us to come together in an efficient fashion to respond to that emergency. Mm-hmm. So, but it was also not just on the clinical side. I felt we needed to create our research enterprise that would focus on issues and needs that were specific to New Mexico. And so understanding nutritional issues from Native American tribes to the issues of the drug use disorders and the problems in northern New Mexico with heroin use, and creating substance abuse councils and responses and backing up hospitals and providers in northern New Mexico. And a number of other initiatives that were really focused to providing, to investigating better ways of delivering health care than what we had been doing. And you know, we're far from perfect now. And it will require a lot more effort. The healthcare system in the United States is wonderful in many ways, but it is not effective in the best way to deliver healthcare to the majority of people. And so that's one area where things like health policy, working with legislatures, with the private sector, and exploring new and better ways to deliver healthcare.
Mm. Yeah, because I feel like you've had a unique position to kind of see what the main health issues are that are facing our state, because almost all the problems come to UNM, right? So like the ones that you mentioned, do you feel like those are like the most pressing issues, and what do you think might be like possible solutions for those as well?
It's very complex because, as I am sure you kind of remember, that public health session first coming into medical school, and we would talk about the social determinants of health, and where things just like education play an important role in determining someone's future health and well-being. Income, poverty, proper nutrition, sense of community and family. Those are things that, unfortunately, we in healthcare don't have an immediate direct control over. But what we can do is to make our voice heard on behalf of those who find themselves in those very vulnerable, difficult situations, and help the legislature in working with health policy and setting up systems that recognize those elements contributing to poor health. So within our system, we were able to create the community health worker. So these are people that would maybe have a high school education. We would train them. They're assigned to some of our clinics that are around the city of Albuquerque. And their job would be to go to patients' homes and ask, how are you doing? They would, if it was a patient, let's say a single mom with a diabetic child, you know, how are you doing on food? Are you able to get your insulin okay? Do you need any help with transportation to get to the hospital? Trying to deal with some of the social issues that we couldn't necessarily eliminate their poverty or their inability to have a car. But we could certainly give them vouchers for cabs or other assistance that would help them at least deal with some of their health care needs. But it still is an embarrassment and a shame that in the world's richest country, we have so many people who can't even afford to go to the drugstore. or find that they're afraid to walk down their street, and for fear of being assaulted. So even if there was a convenient drugstore just a few blocks away, many people feel like they can't get there. So I think first recognizing it, we were able to set up some clinics working with local neighborhoods to have a community garden and have at least some healthy produce, vegetables. We set up another program that we heard about that was very successful in Cleveland. And so we flew out, myself and one of our other leaders flew out to Cleveland, and I met with the mayor and with a few other community leaders. And they created a system in Cleveland where, and we duplicated it here on a smaller scale. But they would go to high schools and identified students who would be willing, if they finished going to high school and didn't drop out, they would have in their senior year multiple sessions that would train them on how to get a job. And things like showing up on time and maybe, wearing decent clothes for an interview, or knowing how to even go to an interview. If they graduated, they went to those sessions, then anchor institutions, most of which were hospitals in Cleveland, would automatically hire them. And so we did that here, and we worked with Presbyterian and UNM and the city of Albuquerque, and we were able to have students finish. They got their high school diploma, and they would go into entry jobs in the hospital. And the thought being that if students were able to at least have a job, they wouldn't be out on the street, and they wouldn't be necessarily, being forced to just have a negative interaction with the law, or to take up drugs. That was the hope, at least. And we found that most, not all, of the students who went through our programs here actually were able to get a job and stay with that facility, stay with that job. And at UNM, we even added, if they stayed with the job at the hospital here, the hospital would help pay for college credits and allow them to start on a career path that would get them out of an entry-level job and get into something that would be more substantial. So those were some things that we tried to work on that focused on the causes of poor health. But again, these are only drops in buckets. We're fortunate to get at least some interest in going, but it would require massive amounts of investment. We were hoping that if we proved the principle, there would be much more enthusiasm, but I think it kind of plateaued out. Didn't get enough interest from APS and from, although the city and hospitals really stepped up to the plate.
Okay.
It was hard to get the public schools to adopt it.
It's interesting.
Yeah.
Yeah. But I think it's it's really good to hear about like some ways at least that, you know, try to address the social determinants of health. Because I feel like, and especially through the program, we talk a lot about the social issues, and it just seems so expansive that sometimes you're like, what do we do? But it's good to see like, okay, there's a place to start to kind of move forward and try to address those things. When it comes to like students or people like us, you know, what do you feel are kind of qualities that you should build almost to be able to in the future take on leadership roles and address the kind of issues that we've been talking about?
Well, you know, it starts with being aware, just as you are, and recognizing that there's something bigger that's happening, and to get the bigger picture of health care in the United States, and to understand what wellness really means. And to be well and to be healthy is more than just not being sick. That there's a lot of other things associated with really trying to be the best you can be and to be successful as a human being. So so much of it being driven by health policy. And so some of the service programs that the school has developed in that first block, working with some of these local organizations that are there to try to provide some relief for patients, whether it's the Mothers Against Drunk Drivers or groups that are there to help the disabled, and being aware of those kinds of circumstances. And so, when we led the public health session this year, we had a patient who was paralyzed, was quadriplegic. And when we asked her what would really make a difference in your life, she said, well, the city could just fix the sidewalks, because she couldn't get down the road because they're in her wheelchair, because there would be uneven or there'd be curbs that she couldn't go over. So simple things like that, and understanding how that could impact somebody's life. So those simple things could make such a big difference in someone's life. But I think it starts with asking the question and being aware that it's being a doctor or electing to go into healthcare is more, can be more than spending your time just with one patient and trying to heal them, that they have a whole life outside of your exam room or the hospital room.
Yeah. Wow. And like in general, I'm just gonna ask, like, what advice do you have for students or anyone?
To
Just moving forward and like being in the position I am or where other people might be at this time.
Well, I think the advice would be similar to what I had just said before.
And also reaching out. I think being willing to go beyond the classroom sometimes. Obviously, your schedules are really tight, and things that are uppermost in a medical student's mind is trying to get through this next block and studying for the test and thinking about step exams, those kinds of things, which are very stressful. But I think allowing yourself the opportunity to consider some of these other issues that impact our our community and try to learn more about what those aspects of life might be outside of the hospital, and ways in which either you as a student or as a physician could make a difference in somebody's life. So, I think the best advice is stick with your studies, do well in school, but also lend an ear to some of these other issues that impact healthcare, not just nationally, but more focused really in your own neighborhood and community.
Is this where you kind of feel like the future of medicine is going?
Yeah, I think it has to. And as I mentioned earlier, our society, as advanced and as wealthy and powerful as it is, has really missed the main point of what a civilization and a society is really all about. And I think if you were to look back, a society or a civilization is often viewed as successful if it builds big buildings, and it's very powerful and can assert itself internationally. But I think the legacy that any society really has is how it treats its most vulnerable people. And in that regard, I think the legacy in our society is lacking.
Wow. That's very powerful. Well, I think that's kind of all the questions that I had.
Okay, well, it was a pleasure talking with you.
Yeah, I really appreciate it. And when it comes to like my experience here at UNM, I have to say I think a lot of people are looking beyond the classroom and seeing what they can do to help out in the streets or homes or whatever issues they see. So it's really exciting as a med student here. So
Good. I'm very glad to hear that.
yeah, thank you for your time.
You're very welcome.
Cool.